So yes, I wear a few hats. In my clinical, I'm a neurologist and I see a lot of patients with movement disorders. And I'm also interested in brain inflammation. So this talk really follows on quite nicely from David's talk. And hopefully if the videos work, it's more of a case-based approach. So it really delves into this question of, getting an absolute diagnosis or a genetic diagnosis, I suppose, doesn't matter. I mean, that's the fundamental question and important to families and to clinicians, both from a need-to-know perspective, but also maybe a therapeutic perspective. And so this is a bit of the conundrum. So I'm a clinician who does research, and clinical phenotyping is very important. So what we call things and how we describe things, that's relevant to the majority of this audience. So the words we use. And we sometimes are naughty and we use the words interchangeably, dystonia, dyskinesia, hyperkinetic. Dystonia really means abnormal tone. It's not very useful term. Dyskinesia means abnormal movements. I mean, they're really fairly non-specific. But we use these words interchangeably, and maybe we shouldn't, and some of the cases will help you appreciate why I say that. And I'm going to present some cases of genetic treatable dystonias and dyskinesias which are masquerading as dystonic CP. Some of them not clearly like dystonic CP, and there's lots of red flags, but some of them really do look like your average dystonic CP patient in the clinics. So really, you need to start with a definition. So if we assume dystonic or dyskinetic CP constitutes about 10 to 15% of all cerebral palsy, that's generally what people accept. So dystonia is a movement disorder with sustained twisting movements. Really, that is a dystonic posture, and this is a dystonic posture in the foot. And so dystonic CP is CP in the context of dystonia. The other thing we see with dystonia is often activated by movement, so that when you initiate a movement, you often get extra dystonia, and it can be quite jerky, even tremulous. But it often associates with spasticity and sort of dystonia versus spasticity, and sometimes you accept that some patients have both. So, and what we know about CP is that it's really a syndrome. It's just a collection of patients who have a static motor syndrome due to an insult to the early brain. So we all accept that CP is, a collect-all umbrella definition. And so, does it matter what word you use, dystonia or dyskinesia? So, just to help you appreciate, these are the different movement disorders that we see in children. Tremor is this. Chorea is the Greek word for dance, which means an irregular involuntary movement disorder. I have to be able to impersonate movement disorders. Hope you appreciate this. So dystonia is this twisting movement disorder. Myoclonus are these electric jerks like that. Stereotypies are very common, and they're very common in normally developed kids, and they're repetitive movements, with flapping being probably the most common. And then tics are also a very, very common movement disorder in childhood, of which the most common is sort of repetitive, jerky, fast movements in the face and head and neck. So this is part of the problem. So I've classified dystonic CP and then compared it with genetic dystonia. And you can appreciate that it's not easy to discriminate. So they're both motor disorders. They're both called dystonia. In dystonic CP, it should be static, but we all see patients where the dystonia can change over time, which can be difficult. So you ask the question, are things changing, or is the brain just maturing? Whereas in genetic dystonias, they can be static or progressive. There's usually an abnormal first year of history, whereas in genetic dystonia, that's variable. In dystonic CP, there's sometimes a history of a brain injury, but not always. Whereas in genetic dystonia, there shouldn't be. There shouldn't be a family history in dystonic CP, whereas in genetic dystonia, there may be, but actually most of the dystonia genes are actually new, what we call de novo, so there isn't a family history. And then the MRI brain sometimes shows a brain injury if there was a sort of birth injury, for example, but is often normal. And in the genetic dystonias, it's either normal or shows a specific genetic phenotype. So why is this important? Getting back to my sort of first question. Well, if it's genetic, there could be family implications. If it's treatable, and I'll show you some cases, hopefully, that show that some of these disorders are treatable. And, you know, some families want to understand, and we need to understand more. As you could hear in David's talk, there's many, many unanswered questions, and we can't really answer the fundamental questions for our families often. And then improving our research and understanding. So here are some red flags that this is not your typical dystonic CP. So if there's a family history, clearly that is suggestive of a genetic disorder. However, that family history may be variable, so you may get some different phenotypes. So some patients with a DOPA-responsive dystonia, a parent may have a subtle dystonia or restless legs or other symptoms. In the absence of a defined brain injury, that should be a red flag. I mean, we all have those patients that we call dystonic CP and there's no apparent cause. I suppose those are the patients that should at least have an MRI and then, as David says, maybe consider genetic testing subject to family wishes. And then unusual phenotypes, so fluctuation really by the time of day is a big red flag. If there's big fluctuations, if there's an unusual clinical course, such as a deterioration, and then if there's myoclonus, Parkinsonism or chorea, those are unusual in the context of CP. So hopefully we'll see some videos. I'm a bit put off by this screen. It's not the usual screen, so hopefully the videos are going to play. So case 1 of birth was normal, but the brother has a similar syndrome. So that's an immediate red flag. And the first year was abnormal, and then developed sort of abnormal dyskinetic movements. But it was static. So they have a movement disorder. I'm asking them to put their hands in front of them. And the siblings have these extra movements. They can't stay still. The movement is best described as chorea because it is random and unpredictable. They also struggle to sustain holding the arms up. The girl is more affected than the boy. And they also use what you see in kids with chorea. They usually wedge themselves into the furniture to stabilize themselves. It's a sign of chorea. And they both have genetic mutations. They have actually large microdeletions involving this gene. So as David talked about, this copy number variant, large deletions completely taking out this gene. They have this condition called benign hereditary chorea. Now the word benign is not a very useful term. It's benign in the beholder, you know, so it's benign if it doesn't cause any problems, and it certainly was causing problems for those individuals. And this is another family that was labeled with familial cerebral palsy, which really doesn't really go together, those words. But anyway, that was what was called. And Dad had an ataxic kind of CP, and he certainly did. And whereas the kids had chorea. And here we go. So they have the same condition as the twins before. A colleague of mine says never put two patients together in a video because you don't know which patient to look at. He's probably right, but anyway, I've disobeyed that piece of advice. So they have an excessive chorea movement disorder, and they also had mutations in the benign hereditary chorea gene. But as I said, it's not always benign. There may be a family history unless it's a de novo problem. It's usually non-progressive, but it's usually chorea rather than dystonia. And either a microdeletion, as we heard before, with this large, either contiguous genes, multiple genes, or single gene, or point mutations. But there's other new genes, so many of these conditions, that's a condition that's been known about for maybe 20 years, but this is a gene that was really only discovered in 2014, And this is a gene called ADCY5, which again causes a non-progressive chorea with very early onset. So these patients will be in the CP clinics. It's not very common, so I don't know how common this is in a CP community, but probably well under 1%, I would say. So this is a patient of our hospital, and this family have found this diagnosis empowering and important to them because it has explained the problem. They're going to a meeting in San Diego in a few weeks' time dedicated to this gene, and they are part of a community of families who have this rare genetic condition. So this has been empowering and very positive for this family to get this diagnosis and provide some explanation of why this young lady has this problem. So this is a video of her. You can appreciate she has reduced truncal tone. The movement disorder is best exhibited when I ask her to put her arms up, but you can clearly appreciate her truncal tone is reduced. So I'm asking her to put her arms in front of her. And you can appreciate she has lots of involuntary movements. So I think a blend of dystonia and chorea, probably more chorea than dystonia. So you can see that posture activates the movements. Now, in a way, she's retained the diagnosis of CP for the sense of the therapeutic support she needs, but having this genetic diagnosis has helped the family at least understand. So I talk about this at the end. You know, we don't undo useful diagnostics such as CP, because CP is a term that we all understand and relate to how to support these families. Here's another a different case and a different gene. So these are patients. This is a patient I saw about 6 years ago, and I didn't know what the problem was, apart from I suspected it was genetic. You have to try to be humble as a neurologist because you don't know what you're doing half the time. Gets a bit better every year. Am I right, Michael Shakib? So this is a 2-year-old, no family history, no birth history. And she had a really very profound problem, and again, her movement disorder is quite striking. She has this involuntary excessive movements that are a blend of dystonia with the twisting and turning, and chorea as well. And she was like this the whole of the waking day. In sleep it stopped, as is typical of chorea and usually dystonia. And she has a mutation in this gene called GNA01. What's interesting about it is that this gene has been known to cause a severe epilepsy in the first year of life for nearly 10 years, but only in the last 3 or 4 years have we appreciated it can cause a severe movement disorder, either with epilepsy or without, which is sort of interesting as a neurologist, and it tells you about genes and proteins having multiple roles. That patient had a new de novo mutation, so it wasn't inherited. And here's another patient we've had recently, and this might help you start to appreciate how a genetic diagnosis can help alter treatment. So this is a family I've known for probably 10 years, has a diagnosis of dystonic CP, and he's nearly 16. But he has had 4 severe exacerbations of movement disorders. So he has his baseline is quite a significant dystonic CP, but he gets these profound dyskinetic movements requiring hospital admission for a midazolam infusion for a month. So pretty atypical. And the most recent one, which was last year, was life-threatening. I was pretty worried. We were all worried. This was him. and sort of thrashing around the bed with a sort of dyskinetic, and he was like that all of his waking moments. All we could really do was sedate him. And our treatment, he was on high-dose midazolam and other fairly sedating drugs. So he ended up having emergent deep brain stimulation. So it's sort of an emergency procedure, a surgical procedure, because after about 3 months, he just wasn't settling and he was losing weight, and there were airway problems, chest problems. It was pretty concerning. And I think his family and everyone involved in his care would agree it was life-saving. He has sort of returned back to his baseline dystonic CP. It hasn't cured his dystonia, but it has treated the dyskinetic exacerbations. And the family, he is quite a bright young man who has a happy life and a wonderful family. And he has a good quality of life. So this has been a fantastic success story. And we strongly suspected this gene, and we actually did a whole exome study specifically asking them to analyze this gene, and it was indeed a de novo GNAO1 mutation, and he is similar to the other patients we've seen. So this is important because now we can sort of say this condition seems to be deep brain stimulation responsive, at least in some patients. David's already touched on this. It was just a follow-on from how a gene, what's the context in the CP, and he's critically appraised that paper well. In other words, I'd say 14%, which is what they claim, but actually only 3% had a clear pathogenic variant, and the others are less clear. So we'll move on to a few more cases. And this syndrome is one of those really pleasing disorders to diagnose and treat, and it's one of the things that you always look out for as a neurologist. So it's a young lady who was pretty good, but she had a gait disorder that she'd had for many years and caused tripping, and was labeled as mild dystonic CP. Here's her video. So you'd appreciate, this is a good teaching video, because you'd appreciate at baseline you wouldn't fault that walking too much. But then when you stress the gait, but I'm getting her to walk on her toes, hopefully you'll start to observe that the right foot is turning in and the right arm is not swinging. So we're drawing out a motor syndrome by stressing the gait. And likewise, when I get her to walk on the sides of the feet, we do the same. The important part of the history in this girl was that there were fluctuations. So she was pretty good in the morning and was pretty bad in the afternoon. And that makes you think of dopa-responsive conditions. So dopa-responsive dystonia. Patients do go to rehab clinics, and it's not common, but it's probably the most common single cause of dystonia in childhood. And so it's very important. This is a terrifying pathway of a metabolic pathway, and maybe you can just ignore and phase out for this part of this talk. But essentially, it's how you make dopamine in your brain. So at the bottom, you produce dopamine from different, and there's a block in this pathway. So of about 100 kids with dystonia that we see in the movement disorder clinic, we have about 6, maybe 7 with dopa-responsive dystonia. So it's, given the fact this is an umbrella term, dystonia, it's a relatively important cause. Females are more affected than males. Onset's usually 5 to 10. Can be mild, always affects the limbs, usually the legs, and problems with walking. Here's a young girl and how she presented with, it's a short video, so I'll do that again. Here she goes. It's quite interesting, isn't it, that one? Let's look at it again, because it's an important video, this. So, as you sometimes have with dystonia, you induce it on activation of movement, and there, when we get her to run, you get that sort of real turning, twisting that you can imagine would cause trips. And she was confirmed to have dopa-responsive dystonia and responded beautifully to dopamine, usually low dose, and completely solves it. It is extremely satisfying for the child, family, and the clinician. The only problem is these patients usually don't come back to see you because they're so well, so you can't celebrate their wellness. And then here's another patient, similar story, a boy, no birth history, but the parents unrelated, but had a problem from very early on, and it had high tone and abnormal eye movements. And this is quite an interesting and unusual video, I think you'll appreciate. But you would be understood to say he had CP, and it's a reasonable suggestion. It would be the right kind of word to use, but he's on his toes. He looks like he's got high tone, but look at his arms. They just don't really move. It's not like your typical spastic cerebral palsy posture. They're actually pretty stiff, and they don't really swing. And then he does these rolling eye movements, which are called ocular gyrate crises. So really, that's an absolute hallmark of a dopa-responsive condition. There you go. And indeed, he has, getting back to this friendly slide, a different gene in the different pathway called tyrosine hydroxylase, which results in a specific dopamine deficiency. And the very good thing about this is they're very responsive to dopamine. And this is the same kid, which is a great video. Not bad. You'd be happy with that. This is a video of my colleague Paddy Grattan-Smith, and it's good that you can't hear the Paddy's commentary, because it usually involves a variety of jokes, some of which are funny. But so fantastic outcome, and therefore an important diagnosis, but pretty rare. So we look after 4 patients with tyrosine hydroxylase deficiency, but there was a large report in the international literature reports 40 children, so this is really super rare. So I wouldn't agonize too much about missing it, but I suppose it's looking out for those atypical features like those ocular gyrics. So here, this is a case that sort of plays into David's talk. A 9-year-old boy had some delayed development and developed bulbar problems, and then his motor problems certainly seem to be getting worse. But they've stopped getting worse now. He's now 15, and he's pretty stable. But he has this movement disorder, a turning. So I'm asking him to put he's got some grimacing of his face, some dystonia in his face. He's got this turning dystonic posture of his limbs. He's also struggling to sustain that arm elevation. So that's sign again. And so this is his walking. And again, you can appreciate this asymmetry of his arm swing. He's struggling to heel strike. And he's also got that sort of dystonic posture of his feet. But he had a very large microdeletion involving 19q13.12, which was not considered to be benign. We showed it was de novo and new, and it was very large, so relatively high likelihood of being pathogenic. It involved 40 genes, so we couldn't really work out what gene in that microdeletion. But interestingly, since then, we know that this gene, KMT2B, was described, only just described. And that boy, this gene is completely deleted in his microdeletion. So now we know it's that gene that causes his dystonia, and it's through this sort of piece of work. And this is collecting patients from around the world, 27 patients with KMT2B and dystonia. 27, that's a lot. For a new gene, as David showed, they're showing one family. This is about 27 patients. So there are actually still quite a few dystonia genes out there that are probably undiscovered, and some of them may even be common. And then just the last one that is worth mentioning because it's treatable, a girl with language problems, learning disability, and she gets these unusual motor symptoms. I'll just show this video. And this is after walking. She develops this worsening of her movements, which is quite unusual. It's a sort of, it's a jerky, maybe it's dystonic, but I struggled to use words to describe this, and to be honest, I got her diagnosis quite wrong. But she actually has a treatable condition called GLUT1, so glucose transporter deficiency. And the important clue about this is they get dystonia, which is exacerbated by walking, so exercise-induced dystonia. They usually have seizures as well, so they'll have other symptoms telling you, giving you a clue. But the importance of this is that it responds to the ketogenic diet, so a high-fat diet. And because they struggle to get sugar into the brain, you give them an alternative fuel source, namely ketones. The ketones can be the brain fuel, and they function better. And you diagnose it by showing low CSF glucose and genetically. So moving to just the end of the talk, so useful tests, well, a good history and examination, including family history. If the pattern's unusual or atypical, I suppose the first question is, has an MRI brain been done? Does it show an injury, or is it normal? Because if it's normal, then I think you need to keep your mind open to genetic or alternative explanations. Is it worth doing a CSF? Well, it may or may not be, and that's a clinician and family decision. And then, as David said, exome sequencing, probably for selected patients at this stage, but I think there is this argument that economically, if you make a diagnosis early, you stop repeat MRIs, you stop unnecessary investigations, you stop unnecessary treatments, and you can hopefully make more targeted treatments. And then the other thing to do in unexplained dystonia is a dopamine trial. It's still a very important test to see if they, and in the dopa-responsive conditions, it's usually dramatic. Completely stops the dystonia, or if they're very sensitive, it produces a dyskinesia, which is a very important clue, and that tells you they're super sensitive to the dopamine, and they might have a dopamine deficiency, but you need to go super slow. So you just pick up the phone and ask for help. But essentially, if you're just getting a 10%, 20% benefit, then it's probably not strictly a dopa deficiency syndrome. And the red flags that we've done before, family history, absence of a defined brain injury, a normal MRI, and an atypical phenotype, fluctuations, progressive course, or atypical movement disorders. So even if you find a gene, I don't think undoing the diagnosis of CP has any benefit, maybe apart from dopa-responsive dystonia. You don't retain the diagnosis if you're cured, but otherwise I think it makes complete sense because to retain the diagnosis of CP, because really they still fulfill a diagnosis of CP at the end of the day. So really, it's sort of semantics. But at the same time, defining a genetic cause may help the family in treatment. And of course, this issue of some patients with genetic dystonia are more likely to respond to deep brain stimulation, which is certainly something we are doing not frequently, but increasingly. Maybe 2 patients a year we treat with highly suspected genetic dystonia who are severely impaired. And so in summary, we know that dystonia is a clinical syndrome with multiple causes. I suppose just keeping your mind open to, could it be something else? Could this be genetic? Could this be treatable? Should we try dopamine? Could this be a DBS responsive condition are the primary questions. Thank you very much.